what I'd like to talk about are some novel approaches for treating latent tuberculosis infection. So it's a little bit of a different topic, but with some issues that I think are very key for your setting. So my talk will be oriented around some revisions to the WHO guidelines and, as I'm aware, for South African guidelines for treating patients for preventing TB in HIV-infected individuals. I'm going to talk mostly about some short course alternatives for treatment of or for prevention of TB and clinical trials that are either ongoing or in development that have looked at some of these novel short course regimens and how they've performed in different settings. So, not to belabor the point, but you all know that the risk of developing active TB in HIV-infected individuals is significantly enhanced. And the rates in a normal immunocompetent host, there's about, if you have latent TB infection as defined by a positive tuberculin skin test or a positive interferon gamma release assay, is about 12.9 per thousand person years, which translates to about a 10% lifetime risk of developing active TB. If you have HIV infection, that risk is accelerated to about a 3 to 16% risk per year in individuals with HIV infection. And after an index exposure to an HIV-infected individual, depending on how immunosuppressed they are after that exposure, about 30 to 40% of individuals may develop active TB within the first 3 to 6 months. So that's the setting in which we're talking about preventing active TB in HIV infection. The current approach recommended by the WHO is intensified case finding to find those individuals who have active TB and get them on appropriate treatment to reduce their infectiousness, initiation of isoniazid prophylaxis to prevent TB, infection control in settings where TB transmission is occurring. And I've added, although the WHO referred to it as the 3 I's, I've added, based on some of the data that I've just shown you previously, initiation of antiretroviral therapy has a significant impact in reducing the risk of developing active TB. So how does isoniazid preventive therapy do in HIV-infected individuals? We've had a number of studies, and this is just one representative one, that have done a series of meta-analyses of available randomized clinical trials of TB preventive therapy in HIV. And this one, published in 2010, looked at 12 different randomized clinical trials using any anti-TB drug versus placebo in more than 8,000 individuals. And there was a consistent finding that TB risk was reduced by about 30% overall and 62% for individuals who had a known positive tuberculin skin test. 2 of these studies also showed reduced mortality with isoniazid preventive therapy. One with isoniazid alone in TST positive patients, and one the combination with rifamycin versus placebo regardless of TST response rates. And the efficacy in all of the regimens that were used in these 12 trials was similar overall. The point to be taken away from here is that preventive therapy works in HIV-infected individuals, and in those who are known to have latent TB infection as defined by a positive tuberculin skin test, it works very well in reducing risk. The one key feature in all of the studies that was also similar across all of the regimens was the fact that the effect of IPT wanes over time. And I think there are several new studies that have particularly highlighted this point. But just to start the discussion, the WHO has recently revised in the 2015 issuance their guidelines for TB prevention in resource-constrained settings where TB incidence and transmission are high. And that recent change is highlighted here, that adults and adolescents living with HIV who have an unknown or a positive tuberculin skin test and who have had active TB ruled out should receive at least 36 months of IPT. And this, as in the parlance of the WHO, is a proxy for lifetime IPT. So I can see people kind of smiling in the room because we haven't been very successful at initiating 6 months of IPT. We haven't been successful at getting people through 6 months of IPT. How could the WHO issue a guidance like this when I think there's virtually no chance that we'll be able to keep people on 36 months of isoniazid preventive therapy? But be that as it may, I wanted to go through a little bit of the evidence base for this new recommendation. And this is a meta-analysis. There have actually been 3 randomized controlled trials that looked at prolonged isoniazid preventive therapy at 36 months or longer. And these were examined in a manuscript that was just recently published, comparing outcomes in patients who received continuous IPT compared with 6-month standard of care regimen or its equivalent. In this meta-analysis, irrespective of TST, as you see here in the table, is the same as unknown TST response rate, since several of these clinical trials did not routinely do TST in all patients enrolled. The studies found, and I'll just go through very quickly these data, that continuous IPT was associated with a 2.7% incidence of active TB in high and medium TB risk areas versus a 4.7% incidence of active TB with the 6-month IPT regimen, such that continuous IPT was associated with a relative risk of reduction in active TB of about 40%. So that's about the same you see as IPT compared with placebo. So a significant reduction in the risk of developing active TB when using continuous isoniazid preventive therapy. In patients who actually had positive tuberculin skin tests, there was a more than 50% reduction in risk with long-term continuous IPT. So the bad side here is that grade 3 or 4 adverse events were significantly higher the longer patients continued on isoniazid therapy, although this was not significant in 2 out of these 3 studies, and the adherence rates were substantially lower for 36 months in one of the studies compared to 6 months of IPT. The other piece of good news was the reduction in mortality for those who were TST positive. And this was seen across the 3 studies in their meta-analysis, about a 50% reduction in mortality that coincided with the nearly 50% reduction in incident TB in those who had a positive tuberculin skin test. And this just graphically depicts what this looks like in terms of this risk ratio plot favoring continuous isoniazid therapy over 6 months of IPT, regardless of which study was looked at, and the strength of the differences across those 3 trials. So why is this important in terms of looking at the potential for long-term isoniazid preventive therapy? And as I alluded to in the 2010 Cochrane meta-analysis of those 12 randomized clinical trials, the efficacy of IPT when administered in a 6-month regimen wanes over time, and certainly does so more rapidly among populations who live in high TB endemic settings. This was highlighted very dramatically by the recently published data from Gavin Churchyard's study in the South African mines. Probably the highest tuberculosis rate of anywhere in the world for South African mine workers. And this was a very large cluster randomized trial in which different mines were randomized to either receive 9 months of isoniazid preventive therapy or standard of care, whatever that might be in the mines. And what was shown in that study was that no benefit of IPT therapy in the standard intention to treat analysis. But importantly, what was shown is that individuals who got 9 months of IPT had a rate of tuberculosis that was 2.5-fold lower than at 9 months than individuals who did not get isoniazid preventive therapy. But what you can see from this graph is that after the 9 months of IPT, they went immediately back up to the background rate of tuberculosis that they had before they even started 9 months of IPT. And the significant finding here was that 9 months of isoniazid significantly reduced the TB incidence, but only while they were taking isoniazid. And as soon as they stopped the drug, their incidence rates of tuberculosis went right back up to the background rates that were seen in the non-IPT treated mines. This actually was one of the 3 clinical trials that served as the basis for the 36-month recommendation by the WHO. The original trial was a randomized clinical trial looking at 36 months versus 6 months of IPT in Botswana and published by Samandari. Interestingly, Samandari just published a follow-up study to that original randomized clinical trial that showed significant benefit for 36 months of IPT, but now with data followed out to more than 2,400 days or 5 years after enrollment, looking at what happened to background rates of active TB once 36-month regimen was stopped. And what you can see here is certainly much higher background rates occurring among those who stopped after 6 months, but you also see here that there was a gradual increase up here to almost a 5% TB incidence rate in those individuals who had gotten 36 months of IPT. So not as high as the 6-month regimen, but certainly demonstrating that even the 36-month regimen in high TB endemic settings is not good enough to keep background rates of active TB low, and certainly not good enough to make it equal to those who are not HIV infected. And so I think that's an important point. Is that true of everywhere? And this is another study, that the 3.0 study, that looked at the durability of IPT after discontinuing it in a medium TB and prevalence setting. And this was done in Rio de Janeiro, Brazil. This component of the study is looking at, the original study was, again, a cluster randomized trial in which individuals received, were either started on IPT or not, according to standard of care in the clinical setting in which they were being treated. And so they looked at the rate of TB that occurred in individuals who never received IPT versus those who started any IPT. And this wasn't a randomized trial of placebo versus IPT. It was just a randomized trial of educational interventions in different clinical settings, trying to get people to implement IPT in those clinical settings. And so this component of the analysis is really looking at those interventions that were successful in getting people to start IPT compared to those that were not. But what the important point to be taken away from this slide is that those individuals who did get IPT and were followed out to 7 years still had a significant reduction in their rate of active tuberculosis when compared to individuals who never received any isoniazid preventive therapy, and suggesting that the durability of IPT in this medium TB prevalence setting in Rio de Janeiro, Brazil, was much better than what's seen in a very high TB prevalence setting such as South Africa. One point to be taken here, although the authors interpreted this as having very good durability of IPT, is that this rate of 0.53 per 100 person years is still significantly above the rate of active TB that is seen in a non-HIV infected population. So even though there was a durable effect in terms of benefit of IPT, it never got to the point of what we see in active tuberculosis in non-HIV infected individuals. So we can do better in a medium prevalence setting, but we still can't do the same that we might be able to achieve in patients who are not HIV infected. So obviously there are major obstacles to uptake of IPT. The obstacles that currently exist to uptake of 6 months of IPT still exist regardless of recommendations to prolong that therapy. There's poor adherence the longer the duration, and it may actually be worse if you try to initiate a 36-month regimen. There may be insufficient healthcare infrastructure to support DOT for prolonged IPT and adherence monitoring. There is a substantial risk of toxicity associated with isoniazid, particularly when given for prolonged durations. And there are concerns about the inability to effectively rule out subclinical active TB. And the durability in high TB prevalence settings seems to be limited even with 36-month regimens of IPT, although not as bad as with 6 months regimens. So still substantial obstacles to uptake of preventive therapy. Now, the other point to take away from all of these studies that I've just showed you is that the majority of them were done in the absence of effective antiretroviral therapy. So mostly what we were looking at in those studies was the effect of IPT alone, regardless of the duration. And the durability question is a significant question, but is it the same in people who are on antiretroviral therapy, have immune reconstitution, are fully suppressed for prolonged periods? And there have been significant attempts to evaluate this. Obviously, we have signals from the rollout of antiretroviral therapy in sub-Saharan Africa, and that signal here you can see is that the estimated number of tuberculosis-related deaths among people living with HIV, both globally and in sub-Saharan Africa, have dropped significantly with the availability of antiretroviral therapy. And that's irrespective of what's happening with isoniazid preventive therapy. When you look at the impact of ART on TB incidence, regardless of what study you look at, and these include some of the long-acting studies that I've talked about, the person years at risk and the incident TB cases all favor significant reductions in TB incidence associated with initiation of antiretroviral therapy. The START trial I've already talked about, so I can skip over a lot of that discussion, but another key feature that didn't kind of come out in the original presentation at the IAS, but certainly was in the publication, is that the tuberculosis rate in the START trial in patients who initiated antiretroviral therapy at CD4 counts above 500 was still significantly lower in individuals with immediate ART when compared to the deferred background rate in the deferred arm. And this was highly statistically significant, with the hazard ratio showing almost a 70% reduction in the incidence of TB in the START trial. So that's an important and very key feature irrespective of the other benefits of the START trial. This is the original Botswana 36-month isoniazid therapy arm, and only point I want to make from this study is that they did have a small number of individuals in that Botswana trial on 36 months of isoniazid who did initiate antiretroviral therapy during the course of the study. And when you looked at those who were tuberculin skin test positive, who got 36 months of isoniazid alone, or 36 months of isoniazid with antiretroviral therapy, there was a 96% reduction in the occurrence of TB. So the combination of antiretroviral therapy in that study with 36 months of isoniazid therapy got down to nearly the background rates you would expect to see in an IPT in an HIV uninfected individual. I've also already talked about the Temprano study, so I won't reiterate that one too, but just to make the point that the lowest rates of TB occurrence in the individuals with high CD4 counts was in the group that got immediate antiretroviral therapy plus isoniazid preventive therapy. And this just is an attempt to make the point that the impact of antiretroviral therapy isn't just based on the initiation of ART regardless of the response to it, but there is an appreciable effect of CD4 count on TB risk. If you look here In pre-ART, the risk of tuberculosis was significantly decreased as the CD4 count increased, getting down to a subpopulation hazard ratio of 1 and a CD4 count of 500. When you look at time-updated CD4 cell counts after initiation of ART, again, the lowest risk of TB occurrence was in individuals who had high CD4 counts on ART. And this is a table taken from the Temprano study, looking at those who actually did go on to develop TB when their baseline CD4 count was greater than 500. There was still a rate of TB occurrence in that study, although it was lower than individuals who had CD4 counts of less than 500, with the lowest rate here being CD4 counts above 500, early initiation of ART, and IPT. So the point to be made here is that the ART, in terms of being successful initiation of antiretroviral therapy, is associated with significant reductions in TB occurrence the higher the CD4 count gets and the more prolonged the virologic suppression gets. So the combination of IPT with successful antiretroviral therapy results in quite profound reductions in TB incidence. So that begs the question now, with this new recommendation to prolong IPT therapy, do we really need to do that if we are giving patients antiretroviral therapy at higher CD4 counts and we're having better success? Can we really shorten preventive therapy in the context of antiretroviral treatment? In the interest of time, I'm not going to spend a lot of time, but there have been several efforts to look at short course TB preventive therapy and HIV infection. This one was done in an era that was before we had really effective antiretroviral therapy, basically showing that a short course combination regimen with rifampin and PZA was associated with higher discontinuation rates for adverse events and was not any more effective than a standard regimen of isoniazid preventive therapy. What's come onto the scene now, which I think has improved our ability to look at this again, has been the availability of rifapentine. Rifapentine is a long-acting rifamycin derivative that inhibits DNA-dependent RNA polymerase like other rifamycin derivatives, but its key feature is that it has a serum half-life of 5 times longer than that of rifampicin, and it has broader tissue distribution and higher tissue levels are achieved with rifapentine than with rifampin. It is more potent in vitro against MTB than rifampicin and has greater sterilizing activity in murine models of active TB. So for all of these reasons, there's been a lot of interest in combining isoniazid with a long-acting rifapentine derivative. The drug is associated with adverse events that are similar to those of rifampin, with GI upset and nausea, some dry mouth, diarrhea, and headache, and occasionally hepatotoxicity, although it doesn't appear to have the same rates of hepatotoxicity that might be seen with standard rifampicin. You're all, I'm sure, aware of Neil Martinson's study that was done here in South Africa in Soweto. And this is, again, one of the 3 clinical trials that formed the basis for the change in WHO recommendations to continuous IPT, but also in this trial had a rifapentine isoniazid regimen that was 1 dose of rifapentine isoniazid given once a week for 12 weeks. So a 3-month regimen, dual therapy, once a week for 12 weeks. And the point to be taken away from here is that in the intent to treat analysis with 5 years of follow-up, this was equivalent to rifampin plus isoniazid given twice weekly for 3 months and equivalent to 6 months of isoniazid. So suggesting that it was similar in efficacy to standard of care IPT. The isoniazid continuous therapy performed the best in this trial with the lowest rates of TB incidence, but also higher rates of treatment discontinuation. In the US, we conducted a clinical trial referred to as TBTC Study 26. This was a very large randomized clinical trial that also looked at once-weekly rifapentine and isoniazid given for 3 months using directly observed therapy and compared with 9 months of isoniazid self-administered. And included in this study were HIV-infected individuals and children, as well as HIV-uninfected individuals. And overall, the event rates after 33 months of follow-up showed that isoniazid and as standard of care for 9 months compared with the 3-month regimen of rifapentine and isoniazid given once a week for 3 months were comparable in terms of efficacy and tuberculosis incidence rates, but in the intent to treat analysis, but per protocol analysis, there was a significantly lower rate of TB occurrence in the combination therapy short course INH rifapentine arm. Now, there were only a very small number of HIV-infected individuals that were included in the early release of these data. I'll just skip over that. And so there was a continuation phase of this trial that I'll get to in a moment that looked only at HIV-infected individuals. But just to finish up with the results of this study, the 3 months of isoniazid and rifapentine given once a week was better tolerated than 9 months of IPT. And there was a lower permanent discontinuation rate, a lower hepatotoxicity rate, a lower rate of permanent discontinuation due to hepatotoxicity, and the only difference being a slightly higher rate of hypersensitivity reactions among individuals who got the long-acting rifapentine-containing regimen. The conclusions of the authors from this study was that the 3-month regimen was safe and effective in reducing the TB rate, that its efficacy was comparable to that of administration of 9 months of IPT in a low to medium TB incidence setting, and the completion rate, and the reason that in the per protocol or as treated analysis that the 3-month regimen looked better probably had to do with this difference here, and that's the 82% of individuals completed the 3-month regimen, while only 69.5% completed the 9 months of isoniazid therapy. There is now a recommendation in the United States to use the 3-month regimen once weekly with isoniazid and rifapentine for all individuals as an alternative to 6 to 9 months of isoniazid preventive therapy. And we are now implementing that in most of our public health systems throughout the United States. The HIV-infected population has now been completed in terms of their therapy, and the results were really quite similar, suggesting that this regimen performed as well as 6 months of IPT, even among individuals who are HIV infected. And the time to occurrence of TB, according to the modified intention to treat, although didn't reach statistical significance, was better for the 3 months of isoniazid rifapentine than for isoniazid therapy alone. And this just shows you in tabular form both the modified intent to treat analysis and the per protocol analysis, suggesting that it was at least comparable and perhaps a little bit better than 9 months of isoniazid in this HIV-infected population. So I think using isoniazid and rifapentine in a low to medium prevalence setting was clearly effective, was associated with better treatment completion and lower rates of adverse events, and is clearly emerging as an alternative option to standard IPT in low to medium prevalence settings. What we don't yet have is the durability of this 3-month regimen, as we've seen in the other trials that I've looked at that I talked about in high TB prevalence settings. We may again see the durability of 3 months of isoniazid rifapentine suffering in the context of very high background rates of TB. And that's a research point that remains to be established because it hasn't yet been looked at. There is a rationale for actually looking at even shorter courses. If we can get away with 3 months of once a week isoniazid rifapentine, can we do better if we give daily rifapentine with isoniazid just given for 1 month? And there's currently, we know from animal models, in this case a murine model, that daily rifapentine and INH together for 4 weeks was more effective than rifampicin and INH and indistinguishable from rifampin and pyrazinamide given for 4 weeks in a mouse model. And these were data that were subsequently used in the design of a prospective randomized clinical trial that is still ongoing, with a number of patients here in Durban having been enrolled in this trial. This is an ACTG trial looking at ultra-short course daily rifapentine and isoniazid in HIV-infected individuals who are receiving antiretroviral therapy. Patients are randomized 1-to-1 to get daily rifapentine and isoniazid, and this is being compared with daily isoniazid for 9 months. ART was allowed to be initiated after the first 4 weeks until we had PK data on efavirenz and nevirapine, and once those data were available, and individuals who were already on antiretroviral therapy could also be enrolled. We expect to have results of this trial by the fourth quarter of 2017, by the first quarter of 2017, and I think we will, this should have been first quarter 2017, and I think we'll have information about this as well. This has only a 3-year follow-up in this study. We will be able to look at the durability out to about 3 to 4 years of this short course regimen, and we will have TST or IGRA data on all of the patients enrolled. Just to look at the landscape of isoniazid preventive therapy, there really isn't much going on trying to perfect where we are now. So I think there are a number of questions that remain to be answered in the context of high TB endemic settings. This is the study I just reviewed for you that is still ongoing, looking at ultra-short course isoniazid and rifapentine. There's a study that is being planned by Gavin Churchyard and colleagues to be done in South Africa, Ethiopia, and Mozambique, all among the 22 highest TB rate countries in the world for tuberculosis. And in this randomized clinical trial, they will be looking at a single dose of 3 months of isoniazid given once weekly for 3 months, compared with 6 months of isoniazid, and then compared with annual cycles, and by annual cycles meaning the 3-month regimen once a week for 3 months of isoniazid and rifapentine, but given every year. So attempting to address this concept of 36 months of IPT, but shortening the duration to a cycle of IPT given for 3 months each year. Some of you may think that doesn't sound all that attractive. We still are talking about administering isoniazid and rifapentine. The cost and resource utilization for giving that regimen, even in a dose of once a week for 3 months, is going to be substantial. And if you have to annually cycle that same regimen in HIV-infected individuals, what's going to be the cost effectiveness of that and the resource utilization that will be required to implement that? But I think those are some of the questions that will be addressed in that clinical trial. The AIDS Clinical Trials Group is attempting to look at a similar concept, but now making use of the annual cycle idea, but using this 1-month short course regimen of isoniazid and rifapentine given daily. And again, in higher TB endemic settings, trying to address this lack of durability, even of 36 months of daily isoniazid, but limiting the drug exposure to 1 month each year for individuals who are HIV infected, and then comparing it with what are the two sort of standard of care arms in HIV infected individuals. Importantly, this study is looking at we'll be randomizing individuals who are HIV infected, who have any CD4 cell count, and who are on antiretroviral therapy and virologically suppressed. So looking at whether a single cycle of INH rifapentine will be sufficient if you're on antiretroviral therapy and fully suppressed, or whether annual cycles will be superior in combination with effective antiretroviral therapy in higher TB endemic settings. So where do we go from here? I think I've made several points that I think raise continued research questions in the field. One size clearly does not appear to fit all. The high rate of TB transmission in the mines may be a setting in which lifetime preventive therapy on a daily basis is going to be necessary because they're so highly exposed and re-exposed that intermittent therapy in that setting may not be appropriate. In other settings with slightly lower rates of transmission, you may have the ability to limit exposure to preventive therapy and the drugs that are necessary in that setting, but that remains a research question that we need to establish. Clearly, different uptake and durability will depend on TB prevalence in the settings in which you're practicing. Poor uptake and limited durability of regular standard of care IPT has been clearly demonstrated in some medium to high TB endemic settings. Poor uptake of 36 months of isoniazid is likely to also be the case, and as we've seen in at least the Botswana clinical trial, there may be limited durability even with 36 months of IPT. This shorter course regimen of once a week isoniazid and rifapentine has not been tested in higher TB and prevalence settings, but there are 2 clinical trials in planning that will be testing that setting. The effect of ART at higher CD4 counts on any of the regimens that I've talked about and on the durability of those regimens remains to be tested. And the role of tuberculin skin testing or interferon gamma release testing in identifying those highest risk populations is also a research question that remains. Obviously, we've had significant problems accessing tuberculin skin testing. There are significant problems with just the logistics of getting people back to read tuberculin skin tests. We thought we could overcome some of those issues with interferon gamma release assays. However, those are much more expensive than tuberculin skin testing and really not available in most resource-constrained settings. So I think there's lots of questions still to be addressed in the best manner to prevent tuberculosis in high TB endemic settings. And although we've seen a glimpse of significant reductions when we have people started on ART at higher CD4 counts, we still have work to do in identifying which of those populations and at what threshold we need to administer longer-term preventive therapy. So I'll stop there. Thank you.